Kansingiza Rwanda y'amahanga, Rwanda rwiza, Rwanda rw'imisozi, u Rwanda rwacu rw'ibiyaga n'ibirunga ibiriza boroma. Mirambi myiza y'iwacu amata ateza agatemba, ibibaya bikina inyange ku mugoroba, inyana zitashyema, nimwumve ibyiza by'u Rwanda, ibiyaga byiza by'iwacu hari ikivuna cyahawe, muhazi yo mu Buganza, nibo banzi burera abana, nimwumve ibyiza by'u Rwanda.
noneho nkabaza nese wakoze ikintu ngaho ngera unsubize.
Kera ntabwo twaryaga ibyo kurya byari bibi, twaryaga umutsima gusa, twaryaga imyumbati, twarya ibishyimbo n'amashaza n'ibinyobwa n'amata y'inka.
Ubirunga ibisazi nyamuragira nyiragawe, muhabura yo muhurera, yo habuye abana b'u Rwanda, nimwumve ibyiza by'u Rwanda.
Bose twagenza amaguru ntagire ugenda aho, none wirirwa wicaye bavuga uramukura umwana ugatangira wicaye ugenda mu modoka ukazarinda umusaza mu mugongo rero bitukuye. ubu nanjye ntureba imyaka ngifite ushobora kugenza amaguru rwose ukagenda nkajya kure.
Abakunda ibyiza by'u Rwanda, imitari y'abataramira, izamaza zibasusurutse, amarore bazabari bagize, nimwumve ibyiza by'u Rwanda, niko bimbereye intore. twaganire hamwe umwanzi we tubone mu bumwe n'amahoro nimwumve ibyiza by'u Rwanda mama nimwumve ibyiza by'u Rwanda mama nimwumve ibyiza by'u Rwanda mama nimwumve ibyiza by'u Rwanda nje kubara umutsamba kumbuye nje kubara mutabinzi nje kubara umutsandurutse ijwi ryanjye rigera mu bicu ry'ijuru ry'u Rwanda ngo amazi amagana nje kubara umutsanteri ndino nkanitse cyane ndanguruye ndetse abakobwa bayijyemo n'ab'abahungu bayisohokeye ijwi ryanjye rigera mu bicu ry'ijuru ry'u Rwanda ngo amazi amagana muhore mahama mwihore ariko tubane mu nda mungire bagire muhore mahama mwihore ariko tubane mu
Getting her rhythm back to normal that we could reverse her course and give her back some quality of life. So when you have a tachycardia really from any source that is very symptomatic in causing hemodynamic compromise, heart failure, hypotension, we would recommend doing cardioversion, electrical external cardioversion. And we were able to take this lady, give her sedation so that the procedure wouldn't be uncomfortable. We were able to give her a 200 joule shock using a defibrillator. Like today, I'm anxious to see her and hopefully we'll see continued improvement. I think that cardioversion for that kind of arrhythmia is something you could very easily adopt here.
For it, they need cardioversion. So when the cardioversion is not ready right away, what can be done to help them?
Put on medicines to try to slow her rate. She was treated to try to control the volume overload. So I think those, so beta blockers, calcium channel blockers, amiodarone would be all appropriate things to use to try to manage the rate and bring that down. And that might work in many, many patients. But there will be some patients whose rate is difficult to manage with medications alone. Ideally we'd be able to do the cardioversion immediately. And there are of course other rhythms for which immediate cardioversion is appropriate. You can have a paroxysmal supraventricular tachycardia that's through other mechanisms. You could have atrial flutter with a one-to-one conduction, would be appropriate. You could just have monomorphic ventricular tachycardia. Those would all be situations in which if you have the capacity to do elective cardioversion, you could really improve patients. She's been given amiodarone 200 milligrams a day for the 3 days before we saw her. So when we saw her, we had them increase that to 600 milligrams. You have to, when you use the amiodarone, you have to give loading doses because it only accumulates very slowly. I think 0.25, maybe 0.5 milligrams of digoxin, but the next morning she was still very tachycardic and very sick. So we scrambled around and figured out how we could do the cardioversion for her.
The managing team for that lady, initially we got stuck. The patient was overloaded, and in our case, congestive heart failure, beta blockers are not the right things to be started on. So was having a rapid rhythm, but we could not. When we gave the beta blockers, the overload was severe. What could you advise us in that setting? They are not the right medication, but with the rapid rhythm, the patient may need beta blockers.
So, yeah, I think, beta blockers are very good for rate control and atrial fibrillation, but for that patient, it's really difficult because using beta blockers in the face of decompensated heart failure is not good, right?
Yeah.
Anybody here want to take on the task of putting together a protocol for cardioversion? DC cardioversion?
When I get to the States, if you give me your contacts, I can work with you. One of the incidents, probably will meet with the team we were together. So you need the anesthesiologist who's going to support you to sedate. They have to be part of the team. So in order also assess the situation with you, how compromised your patient is. Not to give too much sedation, like just a patient who's going to surgery. So
you have to be.
Experience between warfarin and those who want coagulation.
Yeah. So what's the preference? Yes.
Yeah. So I mean, here we have issue like with ENR check with warfarin. So we wonder if the patient can afford those who don't want coagulation to just push it.
Yeah, my preference would be always to use one of the NOACs. So Xarelto or Eliquis would be my choice. I think there's evidence that they are safer than using warfarin and slightly more effective. Using warfarin, even in the best circumstances, is really difficult.
There you go.
Now, about my fourth or fifth slide. Going the wrong way. When we look at this population, times have changed as to the distribution of the causes, but there hasn't been real good studies until the echocardiogram was available in Africa, and there were studies done in a few different countries. There was a Rwandan study that I somehow lost in my search of topics, but that was a small study. The causes of congestive heart, can you go back one slide? So the causes of those, of the 5% number has been for years, rheumatic heart disease was predominant, and cardiomyopathy. Hypertensive disease was always lumped together, and it made up about 75%, and only 2% was from coronary ischemic disease. This number is rapidly rising because of rising incidence of coronary artery disease. We didn't know exactly why, but we think she was primary tricuspid valve disease. So there's some interesting problems that may be fairly unique to Africa or to Rwanda, but it probably has not really been defined because there hasn't been that much work done on your population to diagnose properly. But the echocardiogram, I said if there's one study that a cardiologist would have, if I came to Rwanda to practice, and I would take my stethoscope and my echocardiogram, those two things. So the echo is a very powerful tool. There was an echo study done in Cameroon, not that far away, and it showed about this distribution, And each population, go to the next one, each country where there's been studies done have shown a sort of a little bit skew of the types of causes of congestive heart failure. But the bottom line is that we know that the condition exists, and it's a lot of times the key in treatment is to finding a cause. When you get the patient's history, almost 100% have shortness of breath or fatigue. Ask them when their symptoms began and how bad is it. In the United States, we ask people how many blocks do they walk. Maybe in Rwanda, you ask them how many hills can you walk to get home. Are they now so short of breath they must stop 3 or 4 times before they get home? Ideally, you're able to get an echo on them. I think we have plans to come about every 3 or 4 months with Vianney's group. If there's people that you think might have cardiomyopathy or rheumatic heart disease or heart failure, make a list, and you can give it to us when we come, and we can get an echo on them. I don't know if that echo machine that you apparently have here is going to be operative. Ideally, they would get that going, but the technical personnel and the doctors reading it need to be highly trained. So you don't. It would be a shame to have a beautiful machine and not have technicians to be able to get you good studies. In Rwanda, mostly would be the isosorbide dinitrate and hydralazine. Try to get the blood pressure maybe 100 to 110. Lower number around 70. ACE inhibitors, beta blockers, maybe the loop diuretics are best added 1 and 4 to get the blood pressure down, get them less symptomatic, get rid of their shortness of breath or leg edema. Listen to the lungs for rales. Get used to looking at the neck veins for jugular venous distension, and listen closely to the base of the lungs for rales. And hopefully you can get rid of that just by that treatment. So we talked about the hypertension. Since hypertension is a growing problem, we know that. We know how to treat hypertension, and the treatment of hypertension and congestive heart failure is very similar. It seems like the congestive heart failure in the African may be better treated with the hydralazine and isosorbide. Here in sub-Saharan Africa and Rwanda, postpartum cardiomyopathy. I think you guys are probably very aware that in the pregnant woman, towards the end of pregnancy or in the first 6 months after, that cardiomyopathy can occur. And of course, it's a young, healthy woman, delivers their baby, and everything is fine until they get very short of breath. And you get the leg swelling, and usually blood pressure out of control, and those things need to be addressed, like the heart failure. Endocardial myofibrosis is a condition where the heart becomes scarred. I don't think there's a known cause for it. Maybe it's a viral. It is a difficult disease to treat in the teenager, and that's basically echocardiogram diagnosis as well. Thank you very much. It's a pleasure being here.
Nimbe nimbe rate noje